دكتورة دعاء.
Dr. Hisham, yes.
لو ممكن تشاركي, if you can share the PowerPoint slides from your end.
Okay, give me a minute.
Thank you.
You can see the screen now.
Yes, affirmative. Thank you.
Okay. Professor Gaia, do you want to share? Do you want to share from your laptop, or should I take care?
That would be fantastic.
Okay, I will leave the screen.
Okay, so if I have to share, I have to have in the slide presentation mode. Am I right?
Yes, you have to start by the slideshow first. Then you can choose the share screen.
The strange thing is when I have the slide presentation mode, I am not able to do anything else. You know what I mean?
Yeah, you have to navigate between the windows by using the Windows logo, the 4 square on the keyboard.
Windows logo.
But if you don't have any animations or videos in the slides, you can put it as PDF. That, I think, will be much easier for you even to interact with the audience at the same time.
Let's see. Allow to share window. Allow. Let me see if I share the window.
The window logo in the keyboard. You can see it.
No, I can't do anything when I have my slideshow mode. So I have to get out of that to access anything. So I would say you go ahead and share it because of all the confusion, like you did before. I cannot share, I think, the way it's set up.
You are presenting something now?
But I don't see anything here, right? You're playing a video now. Let's see. Nothing is showing up. Yeah, nothing is showing up. So I think it's better if I stop presenting. Okay, so please share what I have given you. There you go. So you'll prompt me when to start. I know you're on break right now. Are we ready to start?
We'll just wait for probably a couple of minutes so that Professor Ali join us.
Okay, can you move back? Yeah, that title is good. Thank you.
Hello, everybody. Shall we start? Mr. Hisham?
Yes, please. We can start right away.
Hello, Prof. Ali.
Professor Ali, you can start the session.
Great, thank you. Well, first of all, thanks to Dr. Almardi for reaching out to me to share what I know about flipped classroom. Dr. Almardi's vision to innovative approaches to teaching and learning is always admirable. So my title, that is focused on engaging students in learning, whether it's in the classroom or outside, using a specific methodology. And now the focus is also on whether they have technology or not. So next slide, please. This is Dr. C.V. Raman, a Nobel Prize winner for his work on light scattering in the different media. And his work in the classroom is what we see. The board is packed with figures and formulae. And if you were in the student position, how easy or how practical it is to learn everything that's going on in the classroom. So this is didactic lecture a professor in the classroom explaining things, and if I were in a student situation, I will be lost. That's my personal opinion. Next slide, please. So didactic lecture may not be the right fit for students. Students often are shy to ask questions in class. When they're taking notes, they miss the key points, and then they may be multitasking, especially with technology in their hands these days. And also because the professor is busy covering the content, there may not be enough time to interact with students. Next, please. So the answer to the issue with didactic teaching is with the flipped classroom. The flipped classroom is where we move the content, the lecture content, outside the classroom so that we can free up the class time to engage students at a one-on-one capacity, and also with peers in a small group activities and so many other activities to engage students. So moving the material, the lecture material outside the classroom to free up time is the main concept of the flipped classroom. Again, to engage students in the classroom as well as outside. Next, please. So there are two components here. One is the students learning on their own. First, the exposure to content is at the individual level outside the classroom, and also coming to class as a group. So this is synchronized place where the instructor will be engaging students with various activities. So I have a number of advantages of the flipped classroom here. By moving lecture content outside, class time is dedicated to practicing the content that has been given, then adding application of the knowledge they have gained, and then to solve problems. What that does is to give exposure to the content multiple times. Once students have explored on their own. Secondly, now they're coming to the class and discussing the same thing again. So it is multiple times that they're looking at the same concepts. So it's also a student-centered classroom. What do we mean by that? Is where students are asked what they could learn on their own, what they couldn't learn on their own. So they tell us where they need our help. So students are asking us to explain one or another concept that is difficult for them, whereas the easier content is learned by themselves. So that is where student-centered classroom, they drive the activities in the classroom, at least the discussion part, where students need help. So the difficult concepts is where we spend more time than all the factual details that they should know. All right, so now then opportunities to work with peers, they can collaborate with them, they learn from each other, and also there is something about students learning from their peers which is more powerful than us disseminating the content. It also prevents cognitive overload. That is, if you were in Dr. C.V. Raman's class, there is cognitive overload. The amount of information you're able to retain is going to be limited, so the rest of it will be gone. You won't be able to keep everything. So in here, because the students are given the content ahead of time, they can break it into chunks. They can learn one concept at one time and the next part another time. So they can break it and plan it, and so learn at their own speed. And when they come to a classroom, it's not new to them. Because it's not new to them, losing all of this information is not as easy, right? So I mentioned about the exposure of content multiple times and at different levels. What I mean by that is the basic details can be picked up by the students on their own. Basic details, the numbers, the factual details, those kinds of things they can learn. And then the difficult concepts like application, analysis, synthesis, these are the details that they may not be able to understand fully, and that's where the classroom environment would help. So another advantage of flipped classroom is it can incorporate other types of teaching, those we know are effective to engage students. Case-based learning, team-based learning, and other modalities like Clicker to engage them at an individual capacity. Next slide, please. So here is a summary of differentiated learning. This is using Bloom's taxonomy. If you have heard about it or using this approach, it shows that the base, the bottom part is the bigger one, that is where the factual details are introduced. Then the comprehension is where the understanding level. So the two blue categories at the bottom, students are expected to learn on their own. Those are the easier details, the easier approaches that students can manage on their own. The top tiers like application, analysis, evaluation, synthesis, these are the ones that we could be practicing in the classroom. So we depend on Bloom's taxonomy in flipped teaching. And again, multiple times of exposure and differentiated learning is appropriate to introduce the concepts at a simpler level first and then add additional details or complex details later. Next slide, please. All right, here is the model of flipped teaching, the flipped classroom. We have two major parts here. One is what happens before class. That's what we call as pre-class. The second part is during class or in class. So before we see the students, we share the content with them for that particular class. So it could be reading, it could be slides, it could be videos, it could be a worksheet, problem solving, any of those activities you believe would help students be exposed to the content. And giving them this content is good, but then whether they are completing this work is another thing we need to keep in mind. That's where a formative assessment of some kind would help students be engaged more, is what the literature says and what my practice all these years also says. So giving them the content for them to do on their own and some sort of a formative assessment is the combination we could call as pre-class. So this is where the introduction to content happens. And during class, we would rehearse this, apply this knowledge, and take them to the higher orders of Bloom's taxonomy. And here assessment could happen, again, formative assessment, along with peers or at the individual capacity, discussion, and various kinds of active learning. So providing feedback of how they're doing in the pre-class material learning as well as in class is another key thing to make them know that if they are well prepared or yet to prepare, and then help them along the way. Next slide, please. All right, so now let's focus on just the pre-class content. This is the first part in the flipped classroom model. And so I'm trying to come up with why this is important. All right, student exposure to new concepts before class as guided by their instructor. Okay, we don't necessarily have to depend on technology if that is an issue. These days, with learning management system and online Wi-Fi, etc., you can also share videos if technology is at your fingertip. So you could assign reading or printed problems or whatever that is practical. And then students can be engaged with or without the need for internet access or electronic devices. Next slide, please. And here, what could be given as pre-class content? Lecture videos, guided readings, practice problems, worksheet, etc. Next one, please. Then the assessment I talked about, it's a formative assessment and to make sure that the students complete their work. If you entice them with some points, then chances of them completing the work is good. And I have noticed that what I do is to give them a quiz in the classroom on the pre-class material before we go deeper into the content. And also I look at their notes that they have taken while they were studying before class, and that could also be given some points. All right, so again, this can all be done in a non-technology format as well. Next slide, please. Benefits of pre-class assignment and assessment: students are engaged before coming to class, so they know what they're going to be learning in class. Content is familiar to students, so they're willing to do more on the same ideas. Factual details are covered in the pre-class content. At least they can pick up those details easily, and there is no need to repeat those again. Have time to focus on difficult concepts in the classroom in the form of mini lecture, discussion, group work, practice problems, etc. So flipped teaching, mind you, is not to say you have to get rid of lectures, but minimize it. Minimize to the level where concepts are difficult and students need to hear it once or more all over again. Next slide, please. So now we switch our focus to what happens during class. Because the lectures are given away, because students know what they have to know about the concepts, what do we do in the classroom? How do we engage them is another important detail we need to come prepared for. Application and mastery of content is what we really want to focus on here. Deeper level of learning. Deeper learning is through repetition, rehearsal, and application of the knowledge that picked up before class. So in class, activities do not have to depend on technology again. Whiteboard discussion, group exercise, and paper copies of the problems, etc., are practical as well. Accountability and active participation is what is important. Accountability of the students. Students are responsible for learning, and they have to come prepared is the focus here, not technology. Okay, next slide. All right, in-class activities that one can use must engage students at their appropriate level. Too difficult, too easy, none of those will keep their attention long. If it's too difficult, they quit. If it's too easy, they finish quickly and leave. So we need to adjust the level based on their preparation, based on their capability. Gauging the level and the type of activities is a challenge for us. But once you figure it out, that's when the excitement of engaging them is uncomparable. Okay, creating these activities demands time, of course. Now one can utilize mini lecture, team-based learning, case-based learning, large group discussion, think, pair, share. These are some activities that I know one can use during class. Next slide, please. All right, digital resources or not. So flipped teaching has been considered as an elite type of teaching method. You need a computer, you need Wi-Fi or internet access, all that. That's where I am now a proponent of a flipped teaching where technology is not necessarily needed. That's where all these details are coming from. Although digital resources can enhance the learning experience, teacher-authored content can still be created in the form of physical materials, worksheets, printed resources. Not all students have equal access to technology. And by embracing low-tech strategies, we can ensure inclusivity, address potential issues related to digital divide. Next slide, please. Now, we saw the advantages of flipped teaching, how we can engage students at different tiers. Now, what are some challenges? Upfront time commitment for us as educators, and student buy-in, faculty buy-in to use this methodology, and then the support from the department or the university. Teachers assume a new role. They're not, the experts of content who are preaching, but they are serving as facilitators, guiding and allowing students to learn from peers and from other sources. There is no formal training on flipped teaching also, so faculty are sometimes scared to start something new that they're not familiar with. And sometimes there are some myths about flipped teaching. Students come prepared is one thing. Most of the time, this is the biggest challenge. In my experience, about 90% of the students do come prepared with all the steps that you have included in your syllabus, but still there is a challenge to engage this last 10% of the students. Must flip the entire course is also a myth. You flip whatever amount that you can, start small and expand over time. Must provide videos is also a myth. You don't have to. You can engage students in other ways also. Poor student evaluation is another myth. No, once students learn the benefits of this method, they can be happy to give you good evaluation. Main thing to make it be successful is communication with students. Emphasize expectations like attendance, video, participation clearly upfront. Create a welcome video for the course introduction. Set consistent deadlines and due dates. Provide regular reminders. Offer tips for students to get organized for learning. Hold students individually accountable. Make class engaging, and must involve a productive interaction. Next slide, please. All right, so there are lots of ways you can communicate. And the last slide that I want to talk about here is what are some pros, what are some cons about flipped teaching. Pros are increased student accountability, student-centered learning and collaboration among peers and between teacher and the students. Lessons and contents are readily accessible anywhere, everywhere. Address multiple learning styles. Increased one-on-one opportunities between the professor and the students. What are some cons? This is where the buy-in is important. Commitment by students, commitment by the professor. Relies on student preparation, which is a challenge. Once you overcome that, things should be easy. A significant amount of work on the front end for students and teachers. Increased screen time if you're using computer technology, and the digital divide is what we are trying to break. Next slide, please. All right, I have some tips here for successful flipped classroom. Do not rush to flip your classroom. Plan well, prepare fully before introducing. Be patient, be flexible, involve peers. It does not have to be one format. There are many formats to do flipped teaching. Get help, be prepared for some changes in student evaluation. Next slide, please. All right, content should be vital to creating a successful flipped classroom. Teacher-authored content is preferred over whatever is available online. How to begin is where you have to start small, allow students to gain confidence with flipped tasks. Be clear about your expectations. Be patient. Students might not immediately recognize how essential it is to do pre-lesson work, and thus may come unprepared for the in-class sessions. It takes some time. Eradicate any misunderstanding. Students could view this approach as the teacher putting the onus on the student to teach themselves. Administrators, perceptions may also be not so supportive. So that's where it's important. Next slide, please. All right, and one more point here, students who take part in a flipped classroom quickly learn that it frees up teachers' time to foster discussion, student collaboration, and group work. What really separates a successful flipped class from an unsuccessful flipped class is the level of support instructor can provide and the communication with their students. Failure of communication, a failure of planning, and not thinking ahead for what could possibly happen in a classroom could cause failure. Thank you. Next slide. So here is a summary. It's a method of active and collaborative learning, allowing integration and application, self-directed and open-ended tasks, peer teaching and learning, inclusive classroom, and social benefits. Next slide. I just wanted to thank my support from various agencies, National Science Foundation, Teaching Career Enhancement Award, Illinois Innovation Network, and the Fulbright Scholar Award. Many students have been involved in my learning and testing and disseminating. Those are mentioned here: Rim, Paige, Hannah, Cheyenne, and Elizabeth. Next one. Thank you. And questions. Next one. Any questions?
Yes, actually, Prof. Kaya, we have this question from Desar. Regarding team-based learning, is it best if students group themselves out, or should they be grouped by the teacher according to criteria that would serve optimum learning experiences?
Correct. The material that you have given ahead of time is put together by the professor for the students at their appropriate level. Okay, so once it is given, it's not that the teacher is not going to do anything. They have to see if they have understood this concept. So that's where the assessments come in. There is some sort of a formative assessment to see where their learning is. And then in the class period, they're asking students where the students need professor's help. So there is a mini lecture. Students may say, I don't understand the cardiac cycle. Can you go over it again? So you should be prepared to explain it all over one more time. So that is where your role is based on the students' needs, students' level of understanding. And then once they have understood, once they have cleared all their doubts, you have to engage them at a different level. This time the level is, as I showed you in the Bloom's taxonomy, you're not giving questions that would cover basic concepts. You would ask how they would apply this knowledge in dealing with the situation. So real world problems are solved, using the knowledge that they have picked up. So there is a lot to be done in the classroom, but it is at a much deeper level.
May I first start by apologizing for the hiccups, Professor Kaya, and to thank you very, very, very much for your participation. And I also need to mention that I learned from Professor Kaya when she delivered 2 workshops, or actually courses, to our teachers in Al Marifa University. And in fact, I was the one who benefited most from those 2 courses, more than the teachers themselves. And it was a first for me, the flipped classroom course, and it was the first for me to hear about the HyFlex approach and all of these things. I also would like to thank Kaya for asking me to present our experience at Al Marifa University in a conference she organized in the USA. I actually presented, and it was a delightful experience for me. Thank you very much. I want to comment to the audience. Now you know when experience speaks. It's not about what she knows. It's about what she really does every day on and on, 24/7. This was her life for the past several years. Thank you very much.
Thank you so much for giving me this opportunity to share my experiences. Yeah.
Okay, if there are no further questions,
Hello.
yes.
May I just ask for a comment, please? Is there a session, a third post-class session for feedback and assessment and evaluation?
So in the two sessions, pre-class and in-class, we would have repeated the discussion over and over, at least 5 to 6 times. So by the time they leave the classroom, we make sure that the details are all thoroughly understood by the students using multiple assessments and activities. So now the same thing is repeated over and over, and that's where we leave it. Post-assessment is actually also done in the classroom after doing all these activities. There is an assessment. It's typically, in my class, team-based learning, where the peers are engaged and they give me their answers. We go over the answers immediately. So what they know, what they do not know is all assessed right away. And post flip teaching is basically the exam on the content.
Thank you. Thank you.
One question from my side, because you are starting applying again and again, and there is always the question of will we be satisfied assessment in the classroom and that's it, or do we need to include the material again in some other sort of summative assessment sometime in the course?
Yes, of course, of course. There are several formative assessments that have been utilized between pre-class and in-class. For me, I give a quiz, an individual quiz over pre-class material, and then I also verify their notes to see if they have done the work before coming to class. Those are my 2 pre-class assessments. And then during class, we do discussion, we do a peer activity of some kind, sometimes the clicker activity. So clicker activity is individual, the team-based learning is group activity. So those are, again, formative assessments to make sure that they have the knowledge. Now, there is a major exam over the content every 4 weeks or so approximately. So that is where they should, again, have studied and do well in their exams. So that is their summative assessment.
Thank you. Thank you.
Professor Kaya,
Yes.
thanks a lot for the very engaging and capturing lecture. I love flipped classroom, and I have experimented with it and the problem-based learning in the same moment.
Excellent.
So I found a very satisfying point that I give my students a chart list where they have to check if the point have been covered or like if there is a problem-based learning. I give them the material before, and the material sometimes it's some kind of a simplified problem with the discussion and the things that they have to read about it, and I give them as hard copy most of the time because of the technology in our country and the situation. So what I do is in the problem-based learning within the lecture, what I do is I give them a check chart that they have to check if this point was covered, or if they had experienced the solution. And then I
Mhm.
give them the problems that they answered to recheck it. I found that to be good. But my problem was always that my students, sometimes most of the students will engage, but some of my students um, are fixated on the idea that this is not how learning is supposed to be,
Right. Right.
because of the secondary school and the previous experience. How
Right.
can you help me, or give me a pointer on giving them this experience, engaging them within this experience?
Well, communication, of course, is the key. You have to show evidence why you're doing what you're doing.
Mm.
And that, there is a lot of literature to support this methodology now. So you may talk about it before the semester, or in your syllabus, or in the beginning of the semester when you're talking to students about your philosophy of teaching. So that is one thing. And then students do observe. It's when they figure out that you're not there to make students learn on their own, you're behind them fully, but your approach is slightly different. They are willing to embrace the difference. They do come around. I have had experiences where there was a lot of rebelling in the beginning, but then the course evaluation said, I learned a lot. It was deeper learning. This is all students saying to you at the end of the semester. So communication, I think, is the key. And
Excellent.
then not giving up, but continuing to practice what you believe in and showing the benefits is I think, the second major task you have.
Yes, perseverance. Thanks a lot. Very
You're
informative
welcome.
lecture. Thanks a lot.
That,
If I may,
thank you very much,
I know
Dr.
Professor
Falan.
Ali wants to close the session and
I'm sorry to
introduce
interrupt.
the speaker, but I remembered one of your researches, Professor Kaya, and you said at the end of the study, the performance of the students after the flipped classroom methodology was applied was positive. They improved, the performance improved, they maintained what they learned and all of that. But when they were surveyed, they didn't actually like it.
Oh, really?
Yeah,
Because it's harder for them.
yeah.
It's very, very highly structured, and they have to continuously keep studying. There is no break for them. The entire semester they're engaged. Whereas in the regular lecture style, they don't study for the first 4 weeks, but whenever there is an exam, that's where they start preparing. So that kind of break is not here. It's regular studying habits that it creates. And many students say that they learn from this course how to study for other courses because of the regular study habits that it creates in them. So,
Okay.
yeah, student buy-in is needed. And I
Yeah.
think by practicing this without giving up, and also other faculty practicing along the side, would simply support the idea that you are bringing some innovative teaching methodology to the classroom.
Thank you. Thank you very much. Thank you.
Thank you for giving me this opportunity.
Thank you.
Thank you very much, Dr. Gopalan, for this enlightening presentation, very practical and really needed. And for this very important concept in medical education, and it's one of the innovative approaches. And has been very interesting discussion. And sorry to interrupt because of time constraints.
Right.
Thank you very much. I think it is time to introduce Dr. Yapin Fayaz. She is the assistant professor, University of Toronto, and she's well known for simulation-based education training in different modalities, especially in pediatrics. And she's going to enlighten us on patient safety through simulation-based education strategies and outcomes. Please enjoy and interact with the presentation. Thank you.
Thank you so much, Professor Ali Al-Ziad. Can everybody able to hear me well? And are you able to see the slides which I have just shared?
Confirm,
Perfect.
Doctor.
Thank you so much. It is my utmost pleasure to be here with you all and share some of the experiences that we have in the simulation-based education. And the topic that we have chosen today is to look at the utilization of simulation to improve the quality of care and patient safety. Just to introduce myself or tell about myself a little bit more. Currently, I'm working in the Hospital for Sick Children, Toronto, Canada, as a pediatric emergency medicine staff physician, and I'm also SimKids medical director, but I'm originally from Pakistan, and I spent some time in Middle East as a staff physician in PEM. So I'm very much always inclined toward looking for how simulation can be aligned in the curricula, not from the starting from a higher level training, but also from the medical student, because we all can remember this and relate to this. Then when we all were medical student, we used to learn about anatomy, physiology, pharmacology, and we used to memorize it without knowing the purpose. What is the application? Why I'm learning about the marking of the bones, why I'm learning about physiology of the heart, and why I'm learning about the cardiac medication. But then when I come to the final year medical school, and then house officer, and then medical field, then I realized that how important are these things are. Likewise, simulation is always being thought that it is a very high cost technology. You need fancy sim center, you need fancy mannequins, which is very costly to incorporate this teaching and learning methodology. But I just think it is not true. Simulation can be done in a very low cost manner, and it can be done in many other ways and outside the sim center. So this is what I'm going to talk a little bit about, and I know I'm going to say a lot of things which might need more explanation. So please feel free to connect with me, because everything which I'm going to tell you about is a whole workshop on its own. So I'm just trying to give you a 36,000 foot view of some of the methodologies that you can utilize with simulation, and that is directly linked to the improvement of the quality of care and patient safety. So if we talk about what I'm going to, I do not have any disclosure or conflict of interest. I'm going to talk a little bit about what is simulation utilization beyond conventional teaching and learning, and then how it can be used for quality improvement and patient safety. So coming to what is simulation, I really want to emphasize on it that simulation is another technique. As Professor Kyle was telling about us, that flipped classroom is one of the technique. Similarly, simulation is a technique which is thought to be as a technology. So simulation is not a technology, it's a technique to replace or amplify real experiences with guided experiences that evoke or replicate substantial aspect of the real world in a fully interactive manner. So you will replicate a situation in a simulated environment and make your learners learn on that in that simulated environment and get ready to take care of the patient. For example, when I learned my first intubation, I still remember there was a neonate that passed away, and I was asked, it is a good opportunity for me to practice intubation on this neonate. So rather than grieving that moment, I was like in the first month of my house job. And now reflecting back, I say whether it was a good thing or a bad thing to do, and I feel so bad that why I have to learn intubation and wait for a patient to die to practice intubation technique. So that comes the role of simulation, especially in acute care procedures or life-saving skills. Simulation-based learning activities are the array of structured activities that represent actual or potential situation in education and practice. And as I provided example, one example is intubation. Other many examples are communication, breaking bad news, or any situation that you want to make your learners learn. These activities allow the participants to develop or enhance their knowledge, skills, and attitude, and to analyze and respond to realistic situation in a simulated environment. So it is a real situation, but you are providing the opportunity to the learner to work in a simulated environment where they are allowed to make mistake, they are psychologically safe, and you are functioning as a facilitator, not as a teacher. So I would like to introduce every one of you, and there's a barcode, and you can scan this barcode through your camera, and it will take you to the website. That it is very important for all of us, especially people who are novice, as I'm in simulation for last 5 years, but I still think I'm learning a lot. So this is a healthcare simulation dictionary that has got all the definition of all the terminologies, because it is very important for us to speak the same language. So every one of us who is involved in simulation-based education have this dictionary on our desktop. So you can download that from this barcode. Another important thing for you as an educator and for all of us is to be aware of what are healthcare simulation standards of best practices. And there are in Axel, a group which has defined 12 standards of healthcare simulation, which is, again, this is the barcode, and it is free to download and free to work upon. And you are free to just scan this barcode and download the standards. I want to introduce an RSIM Center, and by introducing it, any one of you are more than welcome to, whenever you come to Toronto, inshallah, to come and let me know, and I'm happy to arrange a visit for you in my sim center, as well as if anybody of you are interested to do some observership, electives, or fellowship in simulation, you are more than welcome to get connected later on, and I will try my best to make that arrange for any one of you so that you can take it back, this important pedagogy. So our new sim center, we just get a month ago. Our old sim center was only 2-room sim center, and we used to still cater almost thousands of learners in that small sim space. Luckily, we get a new sim center, which is 11,500 square feet simulation space, and it has got multi-purpose rooms, specialty services, debrief rooms, and assessment rooms for conducting OSCEs. So these are some of the pictures of our new sim center. You can see these are multi-purpose lecture hall kind of rooms, or you can change it. These are some of the mannequins that we have. And and this is our 3D printed models that we create. 3D printing models are much more cost effective in comparison to the costly mannequins. So coming to the second point, which is utilizing simulation beyond the conventional teaching and learning methodology. The first pedagogy or first methodology that I want to introduce is interprofessional team training in situ. And what are team training in situ? Team training in situ are the simulations that are physically integrated into the clinical environment. It is one thing to make your learner learn about certain thing, for example, managing a septic shock in a simulated environment in a fancy room. But then when those people come and work in actual, either in a floor, pediatric floor, or into the emergency department, the emergency room is different. Their dynamics are different. The teams that you are are interacting is different. So therefore, it is very, very important to bring those training into the actual environment so that you can learn from that. So the other benefit of the team training in situ is that you can achieve level 4 Kirkpatrick outcomes. There are many, many studies, and they are not recent. They are like almost 10 to 12 years before that simulation-based mock code into actual environment improve the patient cardiac arrest, survival, improve core team performance like communication, leadership, speaking up, ICU cardiac arrest debriefing improve survival outcomes, and there are improved outcome from cardiac arrest in frequent in situ institutions as well. So what we do, we have introduced the team training in situ in June 2011. It happens once in a week, and we have more than 14 scenario. And as Dr. Kaya was saying, we also utilize the flipped classroom methodology, where all the knowledge, because these simulation hour is very costly hour, resource intense. You will have educators, you have a faculty member, interprofessional team participating, you need to use mannequins, etc. So we do not utilize it to deliver a lecture. It is a time to work together and to learn together. So we utilize the flipped classroom, where all the knowledge, all the information has been provided to them regarding CRM principles, PALS guidelines, scenarios, closed loop communication, conflict management. And then when they come, they will do practical work, or they will do hands-on technique. The team training scenarios are these which are showing up onto your screen, and it is actually the actual teams which are like, for example, if today 9 to 10 a.m. is a team training in situ, and if I'm working in the emergency department, then my whole team, like me, myself as a staff physician, my nurses, my medical student, my resident, my fellow will all run that scenario and will practice to manage in the actual emergency department. How we choose those scenarios are based on the most common presentation, any mortality and morbidity cases, any serious safety event that has been bring to the notice, or any new order set, new pathway that has been implemented, so that we can all work whether it is working in our environment or not. So each session is evaluated independently using a case-specific checklist and a validated team score, which I'm going to show you in a minute. And then we do have a physician educator and a nurse educator who will evaluate the team on this checklist, and we do not provide them any summative feedback. It is just for informative feedback, for debriefing, so that to provide them where are the opportunities for us to improve and to do better later. So this is a team score, which is a team emergency assessment measure score. I know it is very small on the screen, but it is a tool with a validated evidence, validity evidence for the non-technical skill, that how is the leadership, how is the team performing or communicating to each other, how is the closed loop communication, and how is the task management. So that one of the focus while we are working together, it is very, very important to work on the non-technical skills portion, especially in the acute care setting. So we do look at the medical management, but the emphasis is also on the non-technical skills too. So this is some of the pictures. I had a videos originally, but then because PowerPoint may cause some trouble, so that's why I am not playing these videos. So you can see this is some of our team trainings which are happening. These are the trauma team training. That's why you are seeing a lot of people. Then afterward, before going to going to the quality improvement and patient safety, I want to let everybody know, because I'm hearing multiple lectures from morning, and I heard a talk about competency-based medical education, etc. So based on this team training in situ, we develop a competency-based medical education program for our faculty. And why we develop that? Because once we become staff physician, our our learning kind of stop. Our new technologies continue to evolve. I have never learned about video laryngoscopy or video intubation, video guided intubation, because it is not at that time when I was doing my residency training. So how I'm going to learn? And if I do not know how I'm going to make my resident learn? And then also everybody come from a different background. So how can we make sure if Jabin is working on a shift versus if staff B is working in a shift, how both of them can provide the same care? So based on the same methodology, we develop a competency-based medical education for faculty member, and there are a couple of publications that we publish. So I just want to bring that up, that I'm so glad when I hear about the competency-based medical education in the Sudani educational paradigm. So coming to the simulation for quality improvement and patient safety, the first thing which I want to mention is the latent safety threats. So what are latent safety threats? Latent safety threats are the threats which are actually present in our environment, but it has not caused any harm to our patient. So for example, there's a banana peel is there, but until unless somebody step on it, will not be able to, will not get slip. So if we are, why don't we wait for somebody to slip and then we will pay attention to it? What if, isn't it be so amazing that we identify it beforehand and then take care of it and then remove that threat from our environment, so that we will make our environment error-free and we will ensure that the quality of care that we are providing to our patient is the best possible care. So this is the pilot data that we collected from our in-situ team training. As I said, those in-situ team training happen into the actual environment. So it was in till the first quarter of 2018. So that is why you can see there were 33 team training happen in 2017 and 12 happened in 2018. So what they showed us that the total, sorry, I will go one slide back. The total latent safety threats that are identified retrospectively from team training in-situ were 70 in number, only from those smaller number of team training. And they are mostly related, they are categorized into crisis resource management, resource system utilization, equipment related, medication related, and medical management related. And then we utilize the SEEPS model, which is a human factor methodology to categorize different themes into one category. One is the medical management, where you can see not using appropriate PPE, need for the hyperkalemia pathway, the CPR ventilation ratio that was done is incorrect. There are some medication related error that we have an electronic medical record system where they found some challenges in putting the medication errors, in insulin infusion orders were wrong, epinephrine dosing were wrong, prostaglandin E2 intubation was wrong, mannitol infusion was ordered wrong. So these are small things which happen every day. Then equipment related, neonatal resuscitation equipment, nobody was able to find where are they located. Nebulization connector was not fitting correctly. There was a mechanism for activation of the teams, neonatal or ICU was not there. So there are so many things that we get out of the latent safety threats. So based on that pilot data, what we did, we implemented this acute event clinical debriefing. And what does acute event clinical debriefing mean? That once we have a resuscitation, for example, we did a septic shock management, actual patient resuscitation. As soon as the patient was disposition was selected, either move to ICU, or if it is a trauma patient, move to the OR or to the imaging suite, then the whole team will sit, will talk about the case for 5 to 10 minutes and talk about what went well in that case, what are some of the opportunities where we will improve, and what are some suggestions for improvement. I'm going to show you a tool in a minute. So if you look at the acute event clinical debriefing, they are immediate, They are usually multidisciplinary because the whole team come together. There should be a structure to it, and it was aimed to provide reflection and analysis how we performed in our actual resuscitation. They are hot debriefs and they are action oriented. And if you look at the why, it is for improving the quality of care. It is not for education or how to do a CPR or how to manage a septic shock patient. They are more focused on improving a quality of care. What we do our triggers for acute event clinical debriefing are intubated patient. If they are getting admitted to PICU, any trauma one, which is a acute multi-system trauma, or any acute neonatal resuscitation. All healthcare professionals which are involved in resuscitation, even it's a social worker, even it is a clerk, even it is a child life support person, they all sit together and talk about it. The lead is usually the MD team lead and the clinical support nurse or a senior nurse. We do it hot, like immediately after resuscitation, in a room, any room which is available. And it is the tool which you utilize. It's called as a ED hot wash tool. This is the tool, and the aim is to just do it for 5 to 10 minutes. You can see the multiple domains, which I'm going to elaborate, but what I want to bring your focus here is that on the back side of this tool, there are some suggestions are provided, some how would you speak? How would you ask the team? So anybody who is even a novice debriefer or a novice person can utilize and use this tool. So you can see here, if you go to the teamwork, what went well, areas to improve, and what are some of the suggestions. Then medical management, what went well, what are the areas to improve, and what are some recommendations. And same is, what are the system related themes, that what went well in the whole system, that is our communication, and how does we manage the patient in the ED. We utilize the plus delta methodology. Plus delta methodology is talking about positive first and then talking about where are the areas for improvement. And the goal is to identify some latent safety threats and performance gap and generate recommendation to benefit the next team and next resuscitation. And why it is useful? It is easy to utilize. There is a minimal training needed, and you can still do it to identify performance gap. And there's no big sim centers are required or no costly mannequins are required for this. So we debrief up till now 56% of the trauma debriefed, 47% of the resuscitation, medical resuscitation was debriefed, and all neonatal resuscitations were debriefed. And these, you can see a big list of the latent safety threats among team, among system, and among individuals have been identified, which I'm not going to go into the detail. So once we identify them, what we will do? Time-sensitive gaps are acted upon immediately. The performance gap and strengths reviewed at the monthly committee meeting. We have created this ED Resuscitation Oversight Committee where we review all these gaps and will send it to the Education Committee if it is an educational intervention. We send it to the Quality Committees, Quality and Safety Committee, if that kind of intervention is related. So they will do some action and they will relay back to us. So what has happened? Loads of new initiatives come into being. We have created some targeted in situ simulation. For example, neonatal resuscitation was not part of the team training in situ. We included the neonatal resuscitation in the team training in situ. We created online modules for the neonatal resuscitation to bring for the nurses, for the respiratory therapists, for our fellows so that they can learn more about neonatal resuscitation. We created this trauma and resuscitation newsletter to provide some ongoing information. And then we created a neonatal order set and updated pathway. New hyperkalemia treatment order set was being generated. We developed some online, like the learning management system, which is for our documentation in the patient. Epic resuscitation notes and epic resuscitation DUG order sets have been generated, and there's loads of collaboration that come into being because of this in NICU, PICU, and acute care transport team. So some of the examples of the process improvement is this, our neonatal resuscitation. We did some neonatal rapid response walkthrough and mini sims, and we created some updated pathways which are shown in the right hand side. And then based on that interactions, we find out that our ICU activation pathway needs some revamping, and we revamped the ICU pathway as well, that you can see on the right hand side too. So I hope I'm able to provide you some ideas what is simulation, how you can utilize simulation beyond the conventional teaching and learning, and still able to provide some more higher level discussions and teaching and learning opportunities, and where are some of the avenues where simulation can still be utilized for quality improvement and patient safety. So this is my email address. I'm pretty cognizant that I have provided a loads of information, but as I said, that this all team training in situ is a full workshop on its own. Acute event clinical debriefing, it's a full workshop on its own. And as I mentioned, CPME is a whole complete separate workshop for hours. So it is just to provide you some insight that how and where you can utilize simulation, even if that resources are not available. So with this, I'm happy to take some Q&As, if any, and then I will provide afterwards some of the societies where you can join for free and you can still contribute or learn more about simulation. Thank you so much. I appreciate your patience listening, and I hope I'm able to provide some kind of thought-provoking thoughts to all of you.
Thank you very much, Dr. Gabin Fayaz. And are there any hot questions, comments, or ideas? Please, in the chat, I can't see anything. Anyone?
Yeah, is there an opportunity for applying simulation-based education using virtual platform?
Okay.
Yes, Noseba, there is a huge opportunity. We do a lot of simulation with Pakistan, with India, and with Egypt, and a lot of that simulation are happening in a virtual platform. And the same, we utilize the flipped classroom methodology. We provide the knowledge part as a virtual gaming simulation, and then the skills part where you have to function as a team, where you have to learn as a team, we do it as a virtual simulation component. And also there is like, I'm happy if your faculty members are interested, even after this workshop, about learning about some of those virtual platforms that you can utilize in your teaching and learning for your students, and starting from medical student up till the faculty member. I'm happy to collaborate with you, or you can reach out to me on my email, and I'm happy to share that more information with you and support if anybody of your faculty is interested in implementing it. Yes, AI and simulation. Thank you so much, Bakri, for mentioning there's a huge opportunity for AI and simulation. The more and more utilization of AI is for creating some case scenarios, as well as utilizing it for communication purposes. The AI has been utilized. Some of the unexplored opportunity which we are started to look up is to video record the various simulation, and then make AI models to look at the team dynamics and non-technical skills based on AI, and provide feedback and improve the more team dynamics and team performance of your teams and faculty member. So definitely, Bakri, there's loads and loads of utilizations which are coming up for simulation. And one of the things that we utilize, or the study has been, one is published and one is accepted, is going to be published soon, is how you can utilize utilize AI-based translation models to improve your communication with the patients for counseling and for history taking as well. Yes, Abir, I
Dr.
completely,
Jabin,
yeah, yes.
thanks a lot for the truly capturing presentation and the subject itself. I'm a maxillofacial surgeon, so I did have a very big problem within my specialty that sadly within Sudan community there is no enough simulation within the maxillofacial surgery emergencies. So most of
Yeah.
the emergencies, the ATLS and the courses were within the modules, and the 3D materials were covering the medical field only, and the maxillofacial was not within that part. So I'm asking about the prosthodontic and the material. How can I contact companies? How can to create the patent and the material, the 3D material that can help me in like a necrotizing fasciitis simulation, in simulation for a vascular vasculature, or some kind of a problem, that the interalveolar fracture, the arch bar, and everything like that for my students and my resident. Thanks a lot.
Yeah, Abhi, I completely echo with what you have said, because these are not a lot of people, like the companies, it's a business for the companies. They only make things which has more utilization. So that is why these dedicated things get missed. So 3D printing is one of the methodology which is coming up. First of all, it is not as costly. For example, I will give you an example of IO, intraosseous insertion. The intraosseous insertion for humerus, the model is not available. So what we did a 3D printing model, and it is much more cheaper than the actual mannequin model, and you can reuse it. Our institute, for example, urology team is doing for circumcision. There's no model available for making learner learn about circumcision. So one of the faculty member connected with our sim specialist, and they created a 3D model for the circumcision. So I know it is difficult, but people are enthusiastic. People like you has to take a lead and try to develop those models and improve the learning. And I am happy to get you connected with some of there's all the big now societies have 3D printing groups who are working, and with the help of low cost moulage solution and skin solution, you can definitely locally create some of the model which are high yield for you. But please connect with me. My email is there, and I'm happy to write my cell number as well if that is easier to connect, and then I will see what are some of the opportunities where I can connect with you, the people which are appropriate and which can help. So I want to bring that everyone's attention. Thanks, Abir, for bringing that important aspect. This is an international pediatric simulation society. It is free for joining for low middle income countries, and all Pakistani members or all members like Sudan, anybody of you. I know it says pediatric, but it is started as a pediatric simulation society, but we are encouraging, I'm one of the board of director in there, so I know we are encouraging other members to join. So please feel free to join the society. Like I will keep this for a minute. And the other thing is Inspire, which is International Network for Simulation Based Pediatric Innovation Research and Education. This is again a free society. I know all of you will not be related to peds, and it doesn't need to be a pediatrician. It can be in any way. If you are doing any pediatric work, that is what is their aim. But then there are so many learnings that you learn from this society, and you can apply from into adult world. And as I said, when it was started as a pediatric societies, but we are encouraging other members to join. So I want to encourage all of you to join the societies. These are free, and you will get tons of information and tons of resources and material from there, and also faculty member to connect and then utilize some of low cost solution into your teaching and learning pedagogies or environments. in our faculty, we are trying to launch a virtual clinical skills project. I will surely, yes, for sure, Nasiba, please reach out to me and I'm happy to help in any way. My motto is like really that I have learned something and how I can support my fellow countries and my fellow people in a way that is low cost solution. So please feel free to reach out to me. Thank you so much, everyone.
Thank you very much, Dr. Gabin Fayaz, for this stimulating session and a nice discussion. And I want to reassure everybody, all the participants, that there is a complete session on simulation later in this program today. Thank you very much, and I'm sure a lot of people will be in touch and in contact with you for more benefit for their themselves and
Yes,
their
thank you.
patients. Thank you.
Yeah.
Thank you very much.
Thank you so much. And I want to thanks once again the whole organizing committee and the whole society for inviting us, giving us this opportunity. And I want to congratulate such a high standard of talks and faculty members who are sharing their experience. I really am learning a lot and enjoying it a lot. Thank you so much.
Thank you very much, everyone. I would like to extend our appreciation for the esteemed speakers who enlightened us with a lot of amazing presentation. And just to remind our colleague, the participants, we have uploaded some of the resources that is related to this session in the resources section in the virtual platform. It will be available through the conference time. Also, we will be sharing more materials to the virtual platform so that everyone will have an access to it. Once again, thank you very much. We'll be starting our next session, so I invite everyone to leave this room and join the next session room. See you there, and thank you very much.